Welcome to the CUGH Faculty Development Webinar Series, Teaching Global Health Through an Interprofessional Lens. This is the second edition of the webinar series, and we're proud today to present the overlays between global health and anthropology. This webinar is being recorded, and so it will be available to you and to distribute to your networks and colleagues. The webinar series is going to have 6 parts and include webinars about global health and engineering, global health and economics, global health and public health, as well as One Health. Please make sure to register for the Global Health and Engineering webinar, which will be coming up on Tuesday, January 31st at 10 a.m. Pacific, 1 p.m. Eastern Standard Time. These webinars are presented by the Consortium of Universities for Global Health, which is a membership organization for institutions involved in academic global health service, research, and education. Both individuals and institutions can join CUGH, and I encourage you to visit www.cugh.org to learn more. The educational products of CUGH are all open source, and this webinar will be available along with a multitude of other resources. This webinar is proudly sponsored by Child Family Health International. I'm the Executive Director of CFHI and also the Chair of the Competency Subcommittee of CUGH. Child Family Health International provides over 35 global health education programs, internships, and fieldwork opportunities for undergraduate, graduate, and postgraduate trainees. Please learn more at www.cfhi.org. CFHI is also a proud member of the Consortium of Universities for Global Health. The webinar series is an offshoot of this article that I want to bring to your attention. This is Identifying Interprofessional Global Health Competencies for 21st Century Health Professionals. This is an open source publication in the Annals of Global Health. The URL is listed on your screen. This is really a seminar article that is codifying and attempting to propose global health competency standards and encourage increased dialogue both from the global north and global south as to the learning objectives and professional development path in global health careers and training opportunities. The webinar series is intended to build upon this article by providing faculty, trainees, and others with tools to teach and disseminate global health through a variety of interdisciplinary lenses. It's very common that we are teaching global health in an interprofessional manner, but we're coming from a certain discipline that we're very familiar with. The goal of this webinar series is to help us all feel more comfortable teaching about other disciplines that we're not expert in, but that are essential to integrate into global health programs and curriculum. Today, we are honored to have Dr. Peter Brown, Professor of Anthropology and Global Health from Emory University. Dr. Brown has a passion for many things, one of which is teaching global health through an anthropological lens to undergraduate through postgraduate students. Welcome, Dr. Brown, and thank you for joining us.
Thank you, Jessica, and it's an honor to be able to try to present at this webinar. You could see from this slide that my outline is pretty straightforward. I want to give a introduction, which is about a basic question of what is anthropology, and then how does it intersect with global health. After that, I'll give a couple of teaching aphorisms that I think are, or quotes that I think are worthwhile for people to kind of get at the gist of what an anthropological approach is to global health, and then provide some basic or key terms for understanding medical anthropology. Then the core of what I'd like to do is to discuss some examples of anthropology and global health. And I'm going to make a critical distinction between anthropology and anthropological research being used within global health programs and research, but also there's something distinctive about anthropology in that it also turns the lens towards the culture and organization of global health programs themselves, which I think is worthwhile for students understanding the necessity of humility and reflection. So And then finally, we'll have some conclusions and some resources that might be useful for the audience. So this is what we're going to do in the introduction. So let's go on to the next one. So in terms of learning objectives for people listening, I just have three, which is for people to be able to define anthropology, which sounds like a stupid question, except for when anthropologists are at cocktail parties and so forth, they often realize that people don't really have a clear idea of what anthropology is. And then, so people should be able to give examples of applied anthropology and within global health interventions, and then an example of a critical medical anthropological analysis of the culture of global health itself. For example, we'll be talking about polio eradication. Let me go on. So, anthropology in its most simple sense is simply the study of human similarities and differences. And it has the notion of having a holistic approach, an approach which is to see all of the connections of what it is to be human. So that involves biology, history, social organization, and the ideas, beliefs, and values that characterize our species. So this holistic approach emphasizes certain things. And if you want to sound anthropological, you always use this word culture, although we'll see when we try to define it that anthropologists have had trouble with that. The other part that I think is very important is anthropologists often emphasize the issue of complexity and context for understanding problems like global health problems, so that it's not necessarily an approach that easily lends itself to simplistic hypothesis testing. Anthropology as a discipline is by nature cross-culturally comparative, but we'll see in a second it is also historically comparative. But this comparative approach, I think, is important because we can have tendencies in other social sciences to try to generalize about human behavior when we all know that the particular context, historical context, the identity of the speaker and so forth are important. And then finally, anthropology has always emphasized the fact that cultures, and here we could see in this little visual that we have a history, there is a change going on. So anthropology departments in the United States are kind of odd in that they can be considered simultaneously bioscience. So here in our building we have 3 labs, one doing human hormone stuff, social science, and we have a number of people here who do work together with public health, and the humanities. So people are working in doing interpretive kind of approaches about different societies. So let me go on. So when anthropologists are often at a cocktail party and people say, "Oh, you're an anthropologist," then they'll ask you where you dig, and that's because we have these kind of understandings of confusing archaeology and anthropology. But what it is that archaeology is part of American anthropology, that is, which uses a 4-field approach. It's an interesting historical fact that our discipline in the United States developed this way, partly because it had to do with trying to understand Native Americans at a time when some theories emphasized kind of racial determinism at the beginning of the at the end of the 19th century. So in the United States, there's this four-field approach which includes biological anthropology, which is about human evolution, osteology, primatology, human biology. And then there's an archaeological approach, but archaeology is really primarily a methodology for trying to understand patterns of cultural change over time and to describe at any kind of point in time what the society and culture was like. So my previous colleague, George Armelagos, was very well known as a skeletal biologist, but his mission was to try to reconstruct the health conditions of previous populations, and he has written about three epidemiological transitions that have happened over time, talking about our contemporary as the third epidemiological transition. Anthropological linguistics is a smaller of the four fields, but it is about how, a lot of it is about how language structures the way in which humans learn to think about categorization, semantics, and so forth. But the largest percentage of anthropologists, let's go to the next slide, are cultural anthropologists, so that they are people kind of in the mold of Margaret Mead who go study other societies and cultures. So historically, let's say in a colonial context, an old saying is that the anthropologists are eccentrics who study exotics, and that is because traditionally lone anthropologists would go to faraway places for extended periods of time and come back with knowledge about how that society or culture works and write books which were called ethnographies about those other societies, like the Trobriand Islanders or the Kung San hunters and gatherers, or and so forth. So today it's not like that. There's much anthropology that's being done in complex societies, including in the United States. So some social cultural anthropology is pretty hard to distinguish from sociology. Some medical anthropology is pretty hard to distinguish from public health, population health, social epidemiology. So anthropologists can be doing both basic research and applied research or action. This is like most sciences, but it's important to recognize for people who are working as anthropologists in global health, most of them have a bit of applied orientation. But people who are doing work on the anthropology of global health are sometimes doing what we would call basic research. About half of the PhD-trained anthropologists every year go into some type of applied research, either working at places like the CDC. There's about 40 anthropologists at the CDC. Many of them are master's degree trained, but they are places like RAND, here in town at the CARE International and so forth. So let's move on here. Now, if we're going to be talking about this discipline, I think it's worthwhile to talk about some of the epistemological underpinnings, that is, what anthropology does not assume and what it does assume. So we can make some distinctions here between psychology, which has influenced health education so much, or other kinds of social science disciplines. And the first one is that anthropologists do not believe that the best level of analysis for understanding health behavior is at the individual level. So we emphasize the approach to understanding humans as within groups. Another thing is that we do not assume that the individuals within groups are really free to choose all of their own personal behaviors, that they live within certain kinds of constraints. And some of these constraints are social and political and economic, but there's also constraints of living within your own culture, your cultural ideas, beliefs, and values that make you see the world in a certain way. So the old saying is that it's hardly the goldfish that discovers water, because we swim in our culture and we're moved along by the current of our culture. It's possible to swim against the current, but it's difficult. Anthropologists do not assume that the environment, if we're talking about nature or nurture, that this idea of the environment or nature is fixed, but rather that humans shape their physical environment. And in many ways, if we could think of environmental health, one of the goals all along of public health in terms of water, sanitation, and so forth, has been to change people's environment. And then finally, I have to say that even though many anthropologists use quantitative methods, we also use qualitative and methodologies, and we really believe that when people tell their stories or in narratives, that's powerful information. So let's move on. Anthropology does assume some of these things, and the assumption is that culture is important. In other words, if we want to understand what humans are, is that humans are the product of a dual system of inheritance, that we inherit genes from our ancestors, just like all other animals, but we also inherit these learned patterns of thought and behavior characteristic of our group. And it is because of our dependence upon culture that humans have been so successful, have been able to live in every environment of the world, including outside of the world, of astronauts or so forth. And that, so culture is a mechanism of adaptation. But culture is also a mechanism that allows people to make sense of the world. In other words, humans and the human brain requires us to create meaning. We are meaning-making machines. And in that regard, anthropology assumes that what people do makes sense in terms of their view of the world, how they think of meaning. So this is the old kind of phrase of understanding somebody by walking a mile in their shoes, but it is that we do not use words like superstition or the idea that these people are ignorant. It is that these would be taboo words in anthropology, but rather we need to understand them from their own perspective. And then there are, as I said before, social, political, and economic factors that are very important in constraining behaviors. And then finally, one of the things I think is relatively important is that if we look at the archaeological record, or if we look at the tendencies in human history, that societies have become more unequal over time. So if social stratification is the differential access to strategic resources, we could see, like in the United States today, with greater income inequality, there's always been inequalities in terms of social power. We assume that in anthropology. The next slide. Okay, so medical anthropology is not one of those four fields, but rather it is a very large and significant part of anthropology in the United States. But it is really can use all of the different theories and methodologies of anthropology and apply it to questions of health, disease, illness, and curing. This image is of a book in the third edition called Understanding and Applying Medical Anthropology. And the first part of the book talks about these theoretical and methodological orientations, which are biological, either cultural ecological or political ecological, ethnomedical, that is studying medical systems themselves, and then critical medical anthropology, which has two flavors. One which is about questioning the epistemological foundations of biomedicine. So this is like science studies. And the other is a more Marxist approach of a political economic approach to understanding health, as well as health problems like drug addiction and so forth. But over half of this book is about the application of these theories within the fields of health care, public health, and so forth. So that these issues like stigma and stigma alleviation, or understanding disability, or cross-cultural communication and cultural competency, these are all areas that concern medical anthropology in general. Next slide. So just about all the anthropologists and global health people interact with our medical anthropologists. But you shouldn't assume that all medical anthropologists are interested in the issues of global health. That's sometimes people might think that an anthropologist is an anthropologist is an anthropologist. Applied anthropologists, who sometimes within the academy have a little bit less prestige, can act as cultural brokers or cultural interpreters for people doing interventions in other societies. And their primary interest is in local communities, both their socio-political organization, their economy, and their cultural belief systems. So this idea in public health about community participation is central to applied medical anthropologists. Well, we've got to part 2, and I have no idea how fast I'm going or slow. But let's continue to talk about how anthropology intersects with global health. Next slide. So one of the things that I think is important, and when you're a certain age like me, is that there was an important, global health is a new label, and it's and what we would call it is there was a discursive shift. There was a shift in which people, okay, I only have people started talking about global health in the 1990s. If it's about globalization, HIV, AIDS, new funding, I'm not sure, but it became very popular for undergraduates. Next slide. So there's some differences between international health and global health, which I'm assuming that all of the listeners know, but some of these that emphasize partnerships, respect, community involvement, I think anthropology is relevant for those. Next slide. So a real basic aspect of global health is that it's not just public health, but it's also the delivery of health care. And two famous medical anthropologists working in global health are Paul Farmer and Jim Kim. And Jim Kim started a project at Harvard called the Global Health Delivery Project. And some of what's important here does have to do with these material needs for delivering healthcare in low resource settings, and that these need to be finely tuned for local context. Next slide. So I'm going to skip over these pretty quickly. You could read them. Every global health intervention is a cross-cultural intervention. Next slide. Public health often involves trying to get people to do things that are good for them, but they don't want to do. This is a dilemma. I like this one because I do work in malaria. If you want to kill mosquitoes, you have to think like a mosquito. If you want to help people, you need to think like them. Or this comment by a Ugandan physician researcher that I think that this is very salient in that he says that we really have to partner with people. And he says, well, if you come to me and say, this is my proposal, are you interested in helping me? He says this is somewhat insulting, that he needs to be treated as a full partner. Next slide. So the final aphorism, second to final aphorism, is that we need to understand the cultural beliefs and practices on both sides of this interaction, which means we need to understand ourselves as well as the, quote, other. Next slide. Finally, I like this quote from Paul Farmer because sometimes I'm very struck by how religion is not part of the discourse in global health, but for the people who we work with, religion is incredibly important, and religion is one way of thinking about the culture of other societies, and the fact that it is almost taboo to talk about it in scientific academia is telling us something about our own culture. Next slide. So finally here, in the interaction between anthropology and global health, I want to say this distinction again of applied anthropology in global health as well as anthropology of global health. I'll be doing this when we get to examples, which I need to move on to. Next slide. Some basic vocabulary. I'm just going to show you these and not really explain all of them. It's all available for anybody to know, but these are some key terms. Next slide. In terms of basic vocabulary, culture is the most important term. And I like this very simple definition. Societies have culture. They're the social structure, but animals have, and even insects have culture. Ethnocentrism is something that all societies have, but it's a problem. It's a tendency to look at other societies from the lens of your own and often judge them as being inferior. So part of a liberal arts education, I think, is to get people to be less ethnocentric. Next slide. So in terms of medical systems, which anthropologists study, there is this emphasis on trying to understand how medical systems work, and they all include a theory of etiology, a system of diagnosis, and then based upon that diagnosis, the prescription of appropriate therapies. But all societies have medical systems that are sometimes difficult to distinguish from their religious systems, since lots of religion emphasizes healing. So people living in just about all societies have the opportunity to take advantage of different kinds of medical systems. I think that this is important, and the way in which people talk about their problems use particular kinds of idioms. And then what Arthur Kleinman has made famous is this idea of people's explanatory models. Obviously, this isn't a book like The Spirit Catches You and You Fall Down. Next slide. So, but there also is an approach which emphasizes the socio-political approaches. Something that has become very important in the field is the notion of structural violence and the social determinants of health, as well as lots of work by anthropologists talking about race being a myth, but there's physical realities of the experience of racism. I won't go into syndemics here. There's a very interesting theoretical concept. Next slide. So anthropology uses particular kind of methods. Ethnography traditionally is long-term in the field, like a year or more, in which people live in the field, anthropologists live in the field and learn from the people around them. Today, most anthropologists are using a mixed methods of qualitative and quantitative approaches, and are also using multi-sites or looking at different levels of analysis. And then there is finally also, I think, an important trend that is to adapt standardized measurement tools for local contexts. Next slide. So here's some examples in and of global health. Next slide. One of the things you should recognize is this is an old topic, and that Ben Paul published a book called Health, Culture, and Community in 1955 when he was teaching at the Harvard School of Public Health. And there's 16 case studies that are really readable today. Next slide. Some of these studies talk about cultural gaps, that is the gap between the culture of the interventionists and the local people. So trying to explain why the promotion of water boiling didn't work in a Peruvian town, or why in another study there was such resistance to local people giving blood samples, or in another case, a famous case by Alan Harwood, why in Hispanic populations, there's a typo here, hot-cold theory of disease affects people's thinking about antibiotics. Or something by Norbert Vecchiato, a notion in Ethiopia that you have to have worms in order to have good digestion. So even the definition of what health is might vary from society to society. Next slide. So there's also, in using anthropology within global health program, some very interesting examples of a miscommunication because something getting lost in translation. So Judith Brown did a study in Cameroon that showed that there was low immunization coverage when rumors started going around that this measles vaccine didn't work, but that was because they had been using a definition which translated as rash illnesses. We know that once rumors start, they're very hard to stop. Or Peter Winch in the area of tropical medicine made some important distinctions about the malaria season in Tanzania, about different categories, that malaria means different things to different people at different times, and this affects the use of insecticide-treated nets. Or Mark Nichter, doing work in India, talks about using a euphemism like weak lungs to patients who have TB and the problems associated with that translation problem. Next slide. One of the things I think is interesting, and one of my recent students, Bonnie Kaiser, is at Duke, doing work in global mental health, has talked about making standard instruments, in this case a depression scale, make sense in the local context. It's Haiti. Next slide. So one of the things that they did in this project was use this concept of idioms of distress, that is, the ways in which people talk about distress. Do not use words like depression or anxiety. So, in fact, a famous ethnomedical study by Art Rubel has to do with susto, or magical fright, which has a lot of things, symptoms in common with depression or PTSD, but it's a different phenomena. Next slide. So, what they did in this regard is do this study on local idioms of distress, and then create, using together with BDI, a different screening device for depression that's being used by Partners in Health in Haiti today. It works a whole lot better because people didn't understand the questions before that. Next slide. Here's another example of an anthropologist working within global health. Mark Nichter is a very famous applied medical anthropologist doing work on, in this case, Buruli ulcer, but he's also done work on tobacco, and a lot of this is community-based participatory research and organization, and how important that is in health service strengthening. Next slide. So he talks about this bottom-up approach and how important outreach is. Next slide. Here's just some pictures. What he talks about is that the outreach education has to start with formative research with people so that they can design interventions that make sense to the people themselves. Next slide. And this includes working with traditional healers. And medical anthropologists, particularly in HIV/AIDS, have done a lot of work trying to cooperate with traditional healers. And often the problem is the need for respect, mutual respect on both sides. Mark does this thing of the traditional healers signing a contract. Next slide. He also has done work on this kind of community-based movement for tobacco cessation and smoke-free households. Next slide. So here we have some examples of anthropology of global health programs. I find these to be very interesting, and the classic is by my friend Judith Justice. This is all the way back in 1976, but is a study of a nurse midwife program in Nepal. One of the stories that I find most telling is that the young women who were hired were from Kathmandu. They were spending all their time trying to figure out how they could get out of the rural sticks and go back to Kathmandu. And in fact, the janitor in the local clinic was doing most of the healthcare provision. Next slide. Part of what is interested in Judith Justice's work does have to do with information only flowing one way, and that's reflecting power differentials. A recent book by Svea Closer called Chasing Polio in Pakistan ended up using the F word in the title, that is the word fail. And she does work on various levels, all the way from the lady health workers whom you see here doing the survey, delivering the vaccines, all the way up to the city level, the regional level, the WHO, and then to the WHO and the CDC. Just like Judith Justice did, to see how a policy gets transformed as it moves towards the people themselves. But in eradication itself, she identifies what she calls a culture of optimism. And the reason why I call this the F word is that talking about possible failure is a taboo within the culture of people working in disease eradication. So that kind of looking at the underlying suppositions or worldview of eradicationists can be something that's very interesting. Next slide. Another way of looking at this, at the systems, does have to do about community health workers. And Kenny Mays and Svea Closer have both done work about the on-the-ground workers in AIDS projects, also polio, but community health care workers in general, what their motivation is. Kenny started his project because he realized that people delivering ARVs and food to HIV-positive AIDS people were food insecure themselves. So next slide. So they tried to do studies of this whole question of, in rural Ethiopia now, we have some people who are being paid and then some who are not being paid. And the issue is, how do we design policies so that people get compensated for the work that they do? Next slide. Then I want to say some things about an excellent book by Joanna Crane, which is about AIDS and the American global health science. And what she does in this book, which might bother people in global health, but that's okay, it is that global health has some paradoxical relationships with inequality. We could even say that the field of global health needs this inequality, and that global health itself is a northern invention and often can marginalize the knowledge produced by southern colleagues. We don't often recognize that the fact that oral rehydration therapy is a technology that came from a low-income country. So in saying that the ideal of partnership is made difficult by these two facts of the culture of global health. Next slide. She makes the recommendations that if we want greater equity in global health, we need to write research proposals collaboratively. So we could think of that quote from before. We need to be aware that healthcare providers and researchers in low and middle income countries are often working in constrained circumstances, that what has been called the normal emergency. And we also have to view our work in capacity building not as aid, or collaborators as aid recipients. Next slide. Then finally, I want to recommend a book for people who are interested in short-term medical missions and interprofessional research. This is an ethnography by Claire Wendland about living in a African medical school for a year, and it tells you a lot about the local health providers and how they experience short-term medical missions, like medical students and so forth. It's very eye-opening. Next slide. And then finally, anthropologists, if there are problems in collaboration, anthropologists are always partly to blame. We have a tendency, and these are 5 ideas that Closer and Finley have suggested, that for better collaboration, anthropologists need to write without jargon. They need to be clear about their methodology. They need to make sure that they get their facts right. And they have to make sure that they recognize their own biases. And then finally, it's not enough just to be critical. You have to be constructively critical and make concrete recommendations for improvement. Okay, I've used up most of my time here, but the next slides are just about resources, and you could go back to them. There's several books that are global health books that this one written by Farmer and the whole Harvard group, most of them anthropologists, Reimagining Global Health. Next slide. Mark Nickner has a wonderful book, a little bit difficult but perfect for teachers, called Global Health: Why Cultural Representations, Cultural Perspectives. I can't read that. Anyway, it's a great book with millions of examples. Next slide. If you're interested in general medical anthropology, I could recommend this because there's 52 different articles and there's good introductions. And the last section of it is about global health. Next slide. And then there's anthropological analyses of policy. One of these by Linda Whiteford, an edited book. Both of these are edited books, but they look at different kinds of global health policies and then how they are experienced on the ground. Next slide. And then finally, the organization that I would send people to look at that's specifically medical anthropological is the Society for Medical Anthropology. And within that society, there are special interest groups, and one of them is critical anthropology for global health, which I am one of the co-directors or co-whatever. Next slide. Okay, now we have time.
Thank you, Peter.
Okay.
Wonderful. On behalf of everyone in CUGH, I just want to thank you, Peter, for that excellent presentation. I think it went a long way to helping us all feel comfortable teaching from an anthropological lens and touching on that in our work. I want to open the floor to questions. And the first question, it comes from Meredith Garton. Can you share those numbers on jobs at CDC, particularly for people with master's degrees? So I think the question is, does the CDC or other institutions like that employ master's level folks, or is it mainly PhD level folks?
Almost none of those people at master's level, none of these people are under a job title called anthropologist. Most of them are health specialists or medical epidemiologists. They do employ people at the anthropology meetings. Every year the CDC has a booth about opportunities. They are much more interested in doctorally prepared applicants, but they're my experience. And that number 40 comes from a survey several years back, so kind of more towards the peak of the AIDS epidemic, and there were a lot of anthropologists being hired because of the so-called hard-to-reach populations, drug users and homeless and so forth. But I know that now there's anthropologists involved in most of the divisions of the CDC, and the director of the Division for Health Inequalities is an anthropologist named Leandris Laberd, and so that anthropology has permeated that huge institution. Also recognize 40 anthropologists out of a staff of thousands and thousands aren't that many.
Thank you. And from Diana Santalon, can you say some more about not viewing capacity building as aid and just go into that in a little more depth about that dynamic?
Yeah, this is something that Claire writes about, and I think it has a lot to do with the capacity building is part of the global health mission. But I think what she's saying, international aid in that sense is that kind of technical assistance or the silver platter approach, so that it's almost an attitude that I'm coming here to tell you how to do it or how we do it in the United States. Is sometimes irrelevant and often off-putting. I think that's more or less what she is saying, that in many ways we could think in global health of we could think of community participation or any kind of partnership as a relationship, and that relationship, both parties get something out of it, and recognize that the people working within global health for NGOs or for research, you are getting your salary, you are getting your career from this, and then the question is what the local people are getting. But there needs to be some humility about what is possible. And this is particularly the case like with our MPH students. You really need a lot of humility. Sometimes you need to, as they say, just be ready to serve the tea and help people move along, but not be forceful about it.
Thank you. Next question. As we go forward into the world of, quote, big data in global health, how do we ensure that deeper understanding and interpretation by anthropology remains important?
I think that's an excellent question, but let me give you kind of one example. I was involved with the CDC in a project on infant diarrhea dehydration deaths in Texas, in the United States. And it was a case-control study. And the questionnaire and the cases were children who were admitted into hospitals with diarrhea, dehydration, and they died. And the controls were children who were admitted into the same hospitals with dehydration and survived. And there was a huge data set that was collected, like a 30-page questionnaire. But Mark Nickner was able to convince them also to do illness narratives. And when I and some students analyzed these narratives, the stories about what the mothers in the control group went through were breathtaking because of the kind of courage and resistance to obstacles that the mothers foresaw. But when we presented this, when the EIS officer presented this data just as epidemiological data, nobody paid attention. But when she used those stories to premise the data, then people were actually crying in the audience. So, humans learn things through stories, and the numbers do not speak for themselves. And so that I think that the value of stories, at least as illustrative cases, is identifiable. But we have in global health quite a few quantiphiliacs, people who just love numbers, and the hegemony of epidemiology is important. Of course, a story is just a story, but that's how we convince ourselves, and that's how we remember things as humans.
Thank you for that. Carlos Ferron from Costa Rica, director of the Inter-American Center for Global Health, says, people from the global north call global health issues what we in the global south call, quote, health issues. This is to say that it seems that every health issue here is a global health problem. Could you comment on how global health, instead of being a place or a magnitude, is more considered an approach to tackling a health issue in a comprehensive manner? Should we strive to look for a new definition that includes a say for global South practitioners?
This is a great question and a wonderful point of view, and I appreciate it. Here at Emory, we are always talking about that you don't need a passport to practice global health, that global health has to do with all communities, and that problem of saying what it's really trying to say is that back in the past when we used that phrase international health was distinguished from domestic health. And what we're saying in a globalized world with permeable boundaries, there's no such thing as domestic as opposed to international health. It is all global. So, but I understand completely that practitioners in the South can feel that particularly North Americans don't recognize that, always recognize that doing work with underrepresented minorities or migrant groups or refugees in the United States or homeless people or the poor in the United States, the hungry in the United States, all of that is global health. And we have these problems in the United States, and we really need to learn from the leaders in the global south what are some of the best solutions to these issues. There's some things like, yeah, that's all.
Yeah, no, I think, Peter, what it makes me think of is there's a power imbalance. You know, we often put in the terms of power and privilege, and that imbalance is what is consistent amongst all those groups with regard to kind of the more normative health system. We have a comment. This is Joanna Crane, author of Scrambling for Africa. In response to the question about not viewing capacity building as aid, that came out of my work within a U.S.-Ugandan HIV research partnership. Some Ugandan collaborators felt that their U.S. colleagues viewed them as aid recipients rather than scientific equals because of the resources they were bringing to the Ugandan clinic to support the research project. So thank you, Joanna, for joining us and for making that comment and bringing additional light onto that question. Another question from Sana from Aga Khan University in Pakistan. Quote, breaking stereotypes is not an easy task. When it comes to their culture, people become very defensive. How can we break stereotypes then?
Breaking stereotypes and combating stigma are huge challenges. And sometimes I believe, maybe that's as an older man, is that this kind of culture change takes generations. But stereotypes like stigma have to be combated with more mutual understanding between groups. And like stigma, or we could think of the phrase from the beginning of the AIDS epidemic, is silence equals death. That silence is, so we need to talk about what are ethnic differences, stereotypes, and so forth. Now, here in the United States, we have an incredible problem with not talking about race, for example, or stereotypes about race and so forth. And we certainly can't use the United States as a shining example of this. So that this stereotyping and stigmatization are types of ethnocentrism, and education and discussion, open discussion and so forth can be, I think, the only thing that I can see. But it is a matter that if we're going to look in terms of overall human evolution, what we define as the we group now, that is our tolerance for others, is much larger than it was in the past. And we also need to recognize that even though the world is full of all sorts of terrible violence and war, there is less war going on now than there was in the past.
Thank you, Peter. Angela Asa asked for further resources on the distinction between international and global health, and I'll just mention that the article Towards a Common Definition of Global Health, which was published by Copland et al. In The Lancet in 2009, is one place to start. There was also a rebuttal, and I'm paraphrasing, global health is public health, or public health is global health, that was also in The Lancet. So those are some places to start, and the articles that have referenced them. Peter, do you have any other favorite resources for the distinction between international health and global health?
Not written. I should, while we're doing advertisements, Svea and I have a book coming out, which is a reader textbook, interdisciplinary one for undergraduates in global health. And I have an essay in there which is about the 19th century roots of international and global health, in which I say global health is the result of this growing together of military medicine and missionary medicine and disaster relief and scientific approaches. You know, there's all sorts of people with different motivations in global health. And you should also say that Jeff Copeland's article, I think is good, but I also think it has some problems.
Thank you so much. So I want to thank Dr. Brown for joining us and remind you all to sign up for Global Health and Engineering and look forward to announcements on the other CUGH Faculty Development Webinar Series, Teaching Global Health Through an Interprofessional Lens. Check out CUGH webinars and membership at www.cugh.org. The recording and slides will be available there. And Child Family Health International is a proud sponsor, and thanks you for attending. Thank you all, and take good care.